Thank you for joining us today. My name is Missy Tuck. I am the program manager at Western Bariatric at Parkview Community Hospital. Today we're going to be talking about obesity and the different ways to combat obesity, including bariatric surgery. There are 3 different types of bariatric surgical procedures that we will be reviewing today. We're going to be talking about the benefits, the risks, and the next steps in the process. So let's get started. So first, we're just going to define obesity. As we can see here, it is a lifelong, progressive, life-threatening, costly, genetically related, multifactorial disease of excess fat storage. It's a mouthful of a definition, but I actually really like this definition because it's just not saying that we're carrying around too much weight. It's all the other stuff that goes along with it. Obesity can impact our health. Once it impacts our health, it can impact our finances, and most importantly, it impacts our quality of life. This definition is from the ASBS, the American Society of Bariatric Surgery. This organization has actually evolved to the ASMBS, the American Society of Metabolic and Bariatric Surgery, because they've discovered the strong link between obesity and metabolism. So if you're ever doing research after today and you see ASBS or ASMBS, it's the same organization. The next slide here is a BMI calculator. BMI stands for Body Mass Index. Body mass index is simply a calculation between somebody's height and weight. Nothing to do with age, nothing to do with gender, but it's a number that helps healthcare professionals gauge risk. So the higher somebody's BMI, the higher risk they are at for certain types of health conditions like high blood pressure, sleep apnea, and diabetes. The way this chart works is essentially you find your height listed on the left and you find your weight listed on the top. You essentially bring your 2 fingers together and then you are able to calculate and see what your body mass index is. If you end up in the red or in the darker yellow, you are likely a candidate for bariatric surgery. So these are the different categories or classifications of overweight and obese. A BMI of 25 to 29.9 is considered overweight. Class 1 obesity starts at a BMI of 30 and goes to 34.9. Class 2 obesity or severe obesity is a BMI of 35 to 39.9. Folks in that category are a candidate for bariatric surgery if they also have something called an associated comorbid health condition. That's a fancy word for something else going on. So somebody with a BMI of 35 with high blood pressure, or a BMI of 37.2 with sleep apnea, or a BMI of 39.8 with type 2 diabetes would be a candidate for bariatric surgery. So again, the folks in that category, the 35 to 39.9, the folks in that category have to have an associated health condition. Or if you have a BMI of over 40, candidates that have a BMI of over 40 are not required to have a health condition to go along with it. At that point, we're trying to prevent those health conditions that I just mentioned. So there are several risks that are associated with obesity. Once we hit that magic number of 30, that obesity category, we see a 55% increased risk in early death, a 70% increased risk of heart disease, a 75% increased risk of having a stroke, and that next one there, a 400% increased risk of being diagnosed with type 2 diabetes. To be very frank with you, that's the #1 reason why we see insurance companies covering bariatric surgery is because it gets very expensive very quickly covering somebody with type 2 diabetes. So insurance companies are financially incentivized or motivated to cover bariatric surgery because they know that patients with type 2 diabetes, their health conditions are often alleviated after surgery. So these next several slides are from the Centers of Disease Control and Prevention. These are some slides that will go over the progression of obesity across the United States over the last few decades. So in 1985, the Centers of Disease Control and Prevention started asking states to report on their obesity rates. The states in the white had not yet started reporting. The light blue states had less than 10% of the population as obese, and the little bit darker blue states there in the Midwest had 10 to 14% of the population as obese. Here we have 1990, 1995, 2000, 2005, 2010, 2016, and now we see 2019. So as we can see here, we are in the yellow with 25 to 30% of the population in California as obese. So again, it's a number that we continue to struggle with all around California and all around the nation. So as our original definition indicated, obesity is a multifactorial disease, meaning not just one thing causes it. These are the three main factors that play into the disease of obesity: genetics, environment, and behavior. This is just a quick visual for us, just showing us how portions have gotten significantly larger over the years. So not only is it a behavioral aspect, so we're consuming more than we used to, but it's also an environmental impact because we are being served much larger portions than we used to back in the day. So normally when we go to a restaurant, the average portion that they serve you is 2 to 3 times the size of an actual serving size. So while we have larger portions, we also have less output due to advancements in technology. Essentially, people are not moving as much as we used to. So what causes severe obesity? Of course, there's low metabolism as one. Excessive caloric intake, that's eating more than what we need, is more of the behavioral component. Inability to feel full, or that satiety or fullness factor. Psychological factors, an example of that would be if somebody does not mindfully eat or they emotionally eat. Genetic factors, and then cultural influences. The take-home message of this, though, is that it's simply not a lack of self-control. This next slide here goes over what some of the medical complications are that are associated with obesity. As we can see here, almost every organ and tissue system in our body is adversely impacted when we carry around excess weight. And it makes sense. The heavier we are, the more work it is for our heart to pump blood to a larger body. The good news is that most of the harmful health consequences of severe obesity from the prior slide are reversible when we lose weight. So these are the different treatment options for obesity. Of course, there's diet, there's physical activity or exercise, there's behavior therapy. An example of that would be if somebody goes and talks to their doctor or a therapist about mindful eating or emotional eating, or even any type of issues that they're having around their diet. Combination therapy, an example of that one would be Weight Watchers, because they encourage good eating patterns, they encourage exercise, and it's in a support group environment. Pharmaceutical intervention, and then of course surgery, which is what we will be discussing in detail today. The statement below there is from the National Institute of Health. The National Institute of Health made the following consensus statement back in March of 1991. As you can see here, they stated, weight loss surgery for the morbidly obese, so folks that are candidates for bariatric surgery, when combined with behavior modification, so support group, is currently the most reliable and only choice for long-term maintenance of excess weight loss. This statement is substantial for a few reasons. Number one, the year. So I started in the world of bariatrics back in 1999. Back then, we performed all of these procedures as open, meaning a patient would have a large incision in the midsection. There was a high complication rate. There was a high wound infection rate. You have a large incision, increased risk of having a wound infection, and the average hospital stay was about 2 to 3 weeks. Although this was the case, the National Institute of Health still says this is the best thing that we got. In the early to mid-2000s, we started performing bariatric surgery via advanced laparoscopy, so minimally invasive. So instead of having a large incision down somebody's midsection, we now have 5 or 6 tiny holes around somebody's abdomen. So because of that, we now have hospital stays that are 1 to 2 nights versus 2 to 3 weeks. Patients no longer have wound infection rates because we have very small incisions. And the risk of dying during bariatric surgery is the exact same as any other abdominal surgery. So your risk of dying during bariatric surgery is the exact same as any other abdominal procedure, like having your gallbladder removed. This next slide talks about why we are here today. Most of the patients that I see every single day are experts in losing weight. It's the maintenance of the weight loss that we struggle with. Most of the patients that I see every single day are expert yo-yo dieters, and this slide kind of talks about why that is. So we all have something called a set point, and our set point controls our metabolism, our digestion, and our energy balance. And it's our body's objective to defend our current set point. And it was something that our ancestors needed back in the day to prevent starvation. So our bodies haven't got the memo that we no longer need the set point. So what happens is when we gain weight, our physiological set point increases, but when we lose weight, our body tries to defend its current set point. They've done a magnitude of studies in our field at watching people and taking labs and doing different types of research, trying to figure out what happens chemically and hormonally with patients who are trying to diet and exercise. What they have found is that patients during their dieting and exercises, once they hit their goal weight, all of their chemicals and hormones are out of whack. Their body is trying to get them back to their initial weight. What they have found is once somebody hits their goal weight, they had hoped that patients' chemicals and hormones would stabilize. But unfortunately, that's not what happens. For about 12 to 18 months after somebody hits their goal weight via diet and exercise, their body is trying to get you back to where you were before. So essentially, our bodies, through chemicals and hormones and metabolic changes, are trying to get us back to our prior weight, our pre-dieting weight. Because of that, the New England Journal of Medicine has released a study stating that 95 to 97% of people that are morbidly obese will regain that weight within 5 years. Right now, bariatric surgery is the only way to alter somebody's set point. 2 of the 3 bariatric surgical procedures that we perform at Western Bariatric at Parkview Hospital alter your set point. So, who's a candidate for bariatric surgery? Western Bariatric at Parkview Hospital is considered a designated accredited national facility. Therefore, we are required to follow National Institute of Health criteria. So here it is in black and white for you. You have to have a body mass index of 40 or a body mass index of 35 to 39.9 with an associated health condition, something like high blood pressure, sleep apnea, type 2 diabetes, and it cannot be your first attempt at weight loss. There is also an age minimum. You must be a minimum of age 18. Ineligible patients. This slide will review the types of patients who will be excluded from having bariatric surgery. Those patients that are actively abusing substances. This is alcohol, drugs, and tobacco. All of our patients must be nicotine-free and not be smoking at all or vaping before they have surgery. There is a nicotine test that is performed to reduce the risk of postoperative complications. Major psychiatric problems. So we are looking at issues that are either undiagnosed or patients who have been diagnosed with psychiatric issues and are non-compliant. Generally, if a patient has depression or anxiety, as long as the issues are controlled, that's not going to be an exclusionary issue. Women who might become pregnant soon. So this one's kind of a double-edged sword. So we receive a lot of referrals from OBGYNs because we have young women who have something called PCOS, polycystic ovarian syndrome, and they are trying to get pregnant. So we receive the referral, and then we are told, yes, we are able to help you. We are able to help resolve your PCOS, but the next sentence out of our mouth is, but we don't want you to become pregnant for about 12 to 18 months after bariatric surgery. Reason is you are losing weight so very rapidly after bariatric surgery, not safe for mom, not safe for baby. So we want to make sure there's a commitment there to not becoming pregnant immediately after bariatric surgery. And those not willing to attend follow-up visits. So bariatric surgery is a tool. It is not a cure-all, it is not a fix-all, but it is an amazing tool that you will utilize for the rest of your life. Patients that come to their follow-up visits and stay compliant with the program have the greatest success. So how does surgery work? All 3 of the procedures reduce our appetite. All 3 of the procedures reduce the amount of food that we can eat during a sitting. All 3 of the procedures help us feel full, even when we eat just a little bit of food. One of the procedures, the Roux-en-Y gastric bypass, reduces the absorption of calories from our intestines. So essentially, we're not absorbing everything that we eat. And also one of the procedures, the Roux-en-Y gastric bypass again, it discourages the consumption of high sugary and high fatty foods by making us feel like crud after we eat it. And this is on purpose. We want you to feel that way. It's called dumping syndrome. So let's say that you have the Roux-en-Y gastric bypass and 7, 8, 9 months later you go to a birthday party or a holiday party and you see a piece of chocolate cake. Let's say you want to eat that piece of chocolate cake. Chances are you're going to feel like you have food poisoning after you eat that piece of chocolate cake. So, and then what happened? And it's all chemically and hormonally related, and we'll get to that when we talk about the anatomy and physiology of the procedure. But then what happens the following week, you go to another holiday party or birthday party and you see chocolate cake, chances are you're not going to want to eat that because you're very vividly going to remember how you felt the prior week. So the first 2 procedures here are our restrictive procedures. The gastric band, some people have heard of the lap band, and then the gastric sleeve, also known as the sleeve gastrectomy. Those are, again, our restrictive procedures. Our combination procedure, which means it's restrictive and also slightly malabsorptive, is the Roux-en-Y gastric bypass. 98% of our patients either have the gastric sleeve or the gastric bypass. Only a couple % of our patient population has the gastric band, and we'll talk about why that is in just a moment. So the picture on the left here is a picture of the gastric band. The picture on the right is a picture of the gastric sleeve. We're going to go ahead and move on to one slide so we can see a better picture of the gastric band. So what we do with this procedure, once we have you in the operating room and we have you asleep, we do about 5 or 6 tiny incisions around the abdomen. Each incision is about the diameter of a Sharpie marker. We actually have one little bit bigger incision with this procedure because we got to fit that band in there. The band is fit in, it's open like a belt, and then it is wrapped around and latched around the top portion of the stomach. Then we have the tubing that just kind of hangs out in our abdominal cavity, and then we have the port down towards the bottom. That port is attached to our rectus abdominis, or our abdominal muscle. The way the band works, our patients have to come to the surgeon's office about every 8 to 12 weeks for the first year or year and a half after you have a band placed and have what we call band fills. What this entails is a surgeon knows exactly where they put that port and attached it to that abdominal muscle. They inject a needle into your stomach and into that port and inject about 0.5 cc to 2 cc's of normal saline. That fluid then travels up the band, up the tubing, and to those little balloon pillows that are wrapped around the top portion of the stomach. Essentially, we're filling up water balloons. So we're filling up water balloons, and then that's pressing against the top portion of the stomach wall. So when we eat something substantial like a turkey sandwich or something like that, if we continue to eat an entire sandwich, an entire foot-long sub, if we continue to eat that, essentially we would vomit that right back out. So this procedure is a decent procedure for folks that quantity eating is the only issue. If you like foods like ice cream, milkshakes, chips, cookies, cakes, anything that's mushy or liquid by the time you swallow, it's going to be mushy or liquid by the time it hits the band, and the food's going to go right through. So the band's not going to do very much for you if you are eating those type of foods. This procedure generally takes a surgeon about an hour to an hour and a half to perform, and patients are generally in the hospital for one night. We're actually going to go back to the prior slide here and look at the picture on the right, which is the gastric sleeve, also known as the sleeve gastrectomy. So this procedure here, we do the same thing. Once we put you to sleep, we're gonna do about 5 or 6 tiny incisions around the abdomen. Once we have you asleep, the surgeon is also going to insert a device into your mouth, down your throat, and into your stomach. This is a guide for the surgeon to make sure that they size and shape your new stomach appropriately. On the right there, you see a C portion of the stomach. That is called your greater curvature, or the fundus of the stomach. We actually remove the greater curvature or the fundus of the stomach. We pull that out one of your little teeny tiny incision sites, and you are left with a new banana-shaped, thinner stomach pouch. So essentially, we are making the stomach just much, much smaller, reducing the size by about 80%. So a lot of times people say, okay, you've removed this portion of my stomach. Can't I stretch my new banana-shaped stomach back out to the size of my old football-shaped stomach? And the answer to that question is technically yes. We can fail any of these procedures. But the reason we don't see that happening very readily is because of those chemicals and hormones that I was talking about earlier when we were talking about the set point. Those chemicals and hormones that control our set point live in that portion of the stomach, and we are removing them. So that is how patients have not only a restrictive element in this procedure, but also a chemical and hormone component of this procedure, because it physiologically alters your set point. As you can see here, we are not touching, transecting, manipulating, doing anything to our small intestines or small bowel. They stay completely intact. All we are doing with this procedure is making our stomach smaller. There is one patient population who would not be a good candidate for this procedure. If you have severe acid reflux or GERD, there is a good chance the surgeon will not want you to have this procedure, because we're creating a very pressurized system in that new stomach pouch. Therefore, a lot of times what happens if somebody does have really bad acid reflux or GERD is it can actually make that condition worse. So chances are, if you have really bad acid reflux or GERD, the surgeon will recommend the Roux-en-Y gastric bypass over the gastric sleeve for you. This is another picture of the gastric sleeve. As we can see here, we are retracting the liver, which lays right on top of our stomach, lays over a good portion of our stomach. So we have to retract that liver so we can gain better access to the stomach pouch. And as you can see there, we are cutting and stapling simultaneously all the way up with titanium staples. And as you can see there, that is on the right-hand side, that's your new stomach pouch. This is a good picture showing you once again, that we are not touching, cutting, manipulating, transecting any of our small intestines, our large intestine, or colon. They stay completely intact. The next picture here is a picture of the Roux-en-Y gastric bypass. This procedure has actually been around since 1963. There was a surgeon in Europe who was doing general surgeries on folks, and he was realizing that his ulcer repair surgery patients were actually losing weight. So he said, hey, how about we do this ulcer repair surgery on folks to help them lose weight and live healthier lives. So that's actually how bariatric surgery was born back in the 60s in Europe. So we have a lot of data on this procedure since it's been around for so long. So again, this procedure is considered a combination procedure, meaning that it's restrictive. We're restricting the amount of food that we can eat during a sitting, and it's also slightly malabsorptive. So as we can see here, we have a teeny tiny stomach pouch that almost looks like a puzzle piece cut from our current stomach pouch. Kind of looks like the upside down V there, like a triangle. That new stomach pouch is about 1.5 ounces to 2 ounces big, or about the size of a hard-boiled egg. So let's start at the word bypass, the S in the word bypass, and pretend that's our mouth. Let's say we eat something, we chew it, we swallow it, and then it goes into our stomach pouch.
For us right now, before we have bariatric surgery, food travels through our stomach and then goes through the first, second, and third foot of our small intestine. Once we have bariatric surgery, we're going to cut at about the third foot of our small intestine and bring the fourth foot of our intestine up and attach that to our new teeny tiny portion of our new stomach pouch.
So let's go back to that piece of chocolate cake that we were talking about earlier. So we're going to chew it, we're going to swallow it, it's going to go down our esophagus, and it's going to hit our new teeny tiny stomach pouch, that triangle looking smaller stomach pouch. That is restriction number 1. Restriction number 2 is our gastric outlet, where food exits our new stomach and then goes into our small intestine. That gastric outlet is much, much smaller. So we used to have an outlet like this big. Now we have an outlet like this big. So we're essentially making our funnel smaller. So our smaller stomach pouch and our smaller gastric outlet forces us to really slow down when we eat and really chew our food when we eat. So those are our restrictive components. Now we have that piece of chocolate cake. As that chocolate cake travels down that new portion of our small intestine, it kind of freaks out. It is asking it to do something it wasn't wired to do. And this is why folks get the dumping syndrome as that chocolate cake or any high sugary or high fatty food is processing through that small intestine. I often get questioned from folks, well, nothing is removed from this procedure. As you can see here, nothing is removed. We don't remove a portion of the stomach like we did in the gastric sleeve. So I often get the question from folks, well, hey, Missy, you said in the gastric sleeve, the whole reason you are removing that portion of the stomach is not only to make it smaller, but also to have that change in our set point, to have those chemicals and hormones that control our metabolism to be altered. We're not removing anything in this procedure, so how do those chemicals and hormones impact our set point? The reason this happens is food is what triggers those hormones to be released. No food is touching that portion of the stomach, so those hormones lay dormant. As you can see there, the small intestine attached to the portion of the stomach is still connected. Therefore it's still alive, it has blood flow there, so it's able to process enzymes and help aid in digestion the rest of the way. With the prior procedure, the gastric sleeve, I mentioned a contraindication, a reason why somebody would not be able to have the sleeve. Same with this procedure. We do have folks that have either colitis, ulcerative colitis, or Crohn's disease would not be a candidate for this surgery, and the surgeons would likely recommend the gastric sleeve instead. This procedure takes the surgeon about 1 to 2 hours to perform, and patients are generally in the hospital for 1 to 2 nights. This next slide here is going to talk about the different types of weight loss that we should expect after each procedure. As you can see here, we have the gastric band on the left, the gastric sleeve in the middle, and the gastric bypass. So when we look at the gastric band, you can see where it says 50% EWL over 2 years. That means if somebody is 100 pounds overweight, they are considered successful if they lose 50 pounds of that over 2 years' time. If you move over to the sleeve, you will see if somebody's at 100 pounds overweight, we see a 65 to 75 pound weight loss, again in about a year to year and a half. The next is the gastric bypass. If somebody is 100 pounds overweight, we generally see about a 70 to 80 pound weight loss. EWL is excess weight loss. I'm just using the 100 pounds as an example. So a lot of those weights, some people say, 50 pounds, if I'm 100 pounds overweight, isn't too shabby. But the numbers below there is what's impactful, that often helps folks make the determination as to what procedure that they want to have. If you look underneath the gastric band, you will see 14% maintenance. That means that only 14% of people are able to maintain that 50-pound weight loss. If you scroll down and look at the gastric sleeve and the gastric bypass, you see those numbers much, much higher. About 70 to 80% of patients are able to maintain that 65 to 75 pound weight loss or the 70 to 80 pound weight loss. This is why 98% of our patients either have the sleeve or the bypass, and only a couple percent of our patients have the gastric band. Back in the day, patients had a much bigger decision to make than you do today. Reason is the gastric band was the first procedure that we performed minimally invasive or via advanced laparoscopy. So back in the day, patients had to decide, okay, do I have the band but lose less weight but have less surgical risk, or do I have the sleeve or the bypass, it be an open procedure, I lose more weight but have increased surgical risk. Now that all three of the procedures have the same surgical risk, that's why the band is now almost a historical procedure. All right, let's talk about some outcomes to bariatric surgery. So this slide was a very substantial study that was done in our bariatric surgery field. So this slide had tens of thousands of patients in it from all around the country. The research scientists were essentially trying to see what type of outcomes patients had after bariatric surgery. What was the long-term sustainability of the weight loss? So they took all of these patients and then averaged them out. The average weight of the patient population was 304.4 pounds. The average weight after 1 year was 192.2 pounds. After 14 years, the average weight of that patient population was 204.7. So as you can see here, about 100 pounds was lost and maintained after a 14-year period. The study also showed the research scientists that patients were able to have their type 2 diabetes resolved. So as you can see at the bottom of this slide, it says, who would have thought it? An operation proves to be the most effective therapy for type 2 diabetes. It's a pretty substantial, exciting study that was performed in our field. This next slide here is called a meta-analysis study, meaning that the research scientists kind of pulled studies from all different facets and combined it into one. So instead of me showing you just one study about sleep apnea and another study about hypertension and another study about asthma, they put it all into one slide for us, or into one study for us. So we were able to see what health conditions did people have resolved after bariatric surgery, and if they were not resolved, at least what kind of improvements did we see in those health conditions. So sleep apnea, we can see 95% of people got to completely do away with their CPAP machine after bariatric surgery. And if you didn't completely get to do away with it, we at least saw 100% improvement where people got to turn down their CPAP levels. Arthritis, we see resolution there and improvement. We see lipid abnormalities. That's if your doctor says your HDLs, your LDLs, your cholesterol, your triglycerides, anything like that are out of whack. Infertility, this is referring to PCOS, that polycystic ovarian syndrome. Diabetes, this is type 2 diabetes. Liver disease, hypertension, that's high blood pressure. CAD, that's coronary artery disease. Asthma, and then congestive heart failure. This slide talks more about our quality of life and overall well-being, also important as the prior slide, but it talks about depression, quality of life, mobility, things of that nature, also significantly improved after bariatric surgery. So while we talked about what some of those benefits are, let's also talk about what some of those risks are and what we do to prevent those risks from coming to fruition. So we can run the risk of a leak during a gastric sleeve or a gastric bypass. So what we do to reduce that risk is we do a leak test in the operating room. The way I kind of think that it looks is if you have a beach ball and there's a little hole in it and you submerge it underwater and you see little air bubbles escaping, it's kind of similar to what happens in the operating room. We can see little air bubbles. We see exactly where that's at. We're able to resuture that, and then we're able to retest, and then there's no more bubbling, so we have no more leaks. Blood clot. This is one of our number one reasons where patients can get into trouble. So it's our number one risk of getting into trouble not only with bariatric surgery, but also with any abdominal procedure. So to reduce that risk, all of our patients have sequential compression pumps, kind of ongoing huggers wrapped around our legs. Some of our patients wear TED hose. It's a type of hosiery that helps aid in circulation. And early post-op ambulation, fancy word for walk-in. So after you have surgery, your nurses are going to have you up walking, usually about 2 to 3 hours after you have surgery, and about every 2 to 3 hours after that. So it's not going to be a very restful stay with us, but it's going to be a very safe stay with us. And the reason that they're going to have you walking is to reduce your risk of blood clot and again, also pneumonia. Bleeding risk. A bleeding risk is something that can happen with any type of surgery. But to reduce your risk with bariatric surgery, we do a pre- and post-operative medical evaluation to make sure that you're not at increased bleeding risk. Gastric outlet obstruction. As I talked to you about in the gastric bypass, I kind of said that our gastric outlet is much smaller after we have bariatric surgery. Again, the smaller funnel. So we initially had a funnel like this. Now we have a funnel like this. Because of that, now we're not going to want you to eat the same type of foods that we did before. Reason is we don't want to block that new gastric outlet. So things like mucky gunky peanut butter, doughy breads, anything that could block that gastric outlet, we're going to want you to avoid. You will have a nutrition education class with our nurse and dietitian before you have surgery to go over what those foods are and to help make sure that you don't have a gastric outlet obstruction. Pneumonia. Again, that's another one of the reasons why we have you walking so soon after bariatric surgery. And we're also going to have respiratory therapy come to see you while you're in the hospital with us. They're going to give you a device called an incentive spirometer. This device is going to help maximize your lung capacity and decrease your risk of pneumonia. So essentially, we're just trying to make sure you stay as safe as possible during your stay with us and after surgery once you're discharged home. Heart attack and death are risk again with any type of surgical procedure, but to reduce that risk, all of our patients go through a head-to-toe evaluation, have many labs and testing done beforehand, so your surgeon, your primary care physician, and also the anesthesiologist can all be on the same page with your care to make sure we have the best outcomes for you. Potential issues after surgery. So dumping syndrome is one, and we talked about that earlier, what that is and why that happens with the Roux-en-Y gastric bypass. Temporary hair loss can occur. We generally see that in folks who after surgery they're not hungry, so they're not eating their protein like they should, and they're not taking their vitamins and supplements like they should. So a lot of times temporary hair loss can be prevented if you stay up on top of your vitamin and supplement regimen and stay on track with your proteins. Gallstones can occur with any rapid weight loss, whether it be surgical or non-surgical. So we will do a gallbladder ultrasound on you before you have surgery just to make sure that we don't already have gallstones in there. If so, we'll want to remove that gallbladder. Stomach ulcers can occur after bariatric surgery if you smoke after surgery, and also if you take any type of NSAIDs after surgery. Things like ibuprofen, Aleve, Motrin, anything aspirin, anything like that. You are still allowed to have Tylenol or acetaminophen after bariatric surgery, just not any of the ibuprofen, Aleve, anything like that. And then increased fertility, that's because of that PCOS that I talked about earlier. The nutritional deficiencies can occur after bariatric surgery if we don't take our vitamins and supplements like we should. So because of that, we want to make sure we know that you're going to not be consuming the same amount of food that you ate before surgery after surgery. So therefore, we want to make sure that you are still getting the micronutrients that you need after surgery, and we want to check on that periodically. So on the left, you will see deficiencies that we're looking to prevent, and on the right, you will see the supplements, some of the supplements that we're going to encourage you taking after bariatric surgery. We draw labs on you at 6 months after surgery, 1 year, and every year after that. So you will be taking these vitamins and supplements for the rest of your life. You will have an education class with our nurse and also with our dietitian before you have surgery to go over what your vitamin and supplement regimen will look like after surgery. So Western Bariatric at Parkview, we are considered a designated MBS equipped center, meaning that we have quality outcomes and we are accredited nationally. Our clinic, our surgeons, and our hospital have all passed the test required to be nationally designated. We have been performing bariatric surgical procedures since 2007, and we have performed over 5,000 bariatric surgical procedures. When you stay with us at the hospital here at Parkview Community Hospital, all of our bariatric rooms are private rooms. Our patient to nurse ratio is much lower, so you have more one-on-one TLC care. And all of our rooms are specifically designated for our bariatric surgical population. So it's something that we're very, very proud of to make sure that you stay nice and comfortable throughout your stay with us. These are our affiliated surgeons. These are the surgeons who will be performing bariatric surgery on you. One of these surgeons will be your bariatric surgeon. We have Dr. Cron, we have Dr. Bernstein, we have Dr. Martin, and we have Dr. Wong. All absolutely amazing, amazing bariatric surgeons. Thanks so much, and I hope you have a wonderful day. And thanks for learning about bariatric surgery at Western Bariatric at Parkview Community Hospital.